So we are going to go ahead and get started. Good afternoon, everyone, and thank you for joining us for the webinar, What to Know About Heart Failure. My name is Elizabeth Aloni. I'm with Schneps Media. Schneps Media is the largest local media company in the Metro New York area. We publish over 80 newspapers, magazines, websites, webinars, podcasts, and events throughout Queens, Brooklyn, the Bronx, Manhattan, Westchester, Long Island, the East End, Philadelphia, and now Palm Beach, Florida. And we are thrilled to be able to bring to you this extraordinary webinar. You know, at New York-Presbyterian, you have the ability to access Columbia and Weill, Cornell medicine, heart failure, and transplant specialists. Patients travel from around the country and around the world to seek the care of their world-renowned doctors. They're a national leader in heart failure, heart transplant, and mechanical circulatory support, and regionally perform more heart transplants and artificial hearts than all the other New York hospitals combined. Their hospitals have 3 times more heart failure specialists than any other hospital in New York. In addition to their expertise and experience, their patients have expressed time over time they come to New York-Presbyterian because of their doctors' compassion and empathy. Their entire clinical staff is dedicated to their patients and their well-being. And as someone who has interviewed many doctors from New York-Presbyterian, I can attest to the fact of their kindness and their authenticity right here. And you'll have an opportunity to meet some more of them today. We really are very lucky to have 3 of these incredible doctors with us, and it's my pleasure to introduce them. So first, I want to welcome Dr. Gabriel Sayer. Dr. Sayer is the Associate Director of Advanced Heart Failure, Cardiac Transplantation, and Mechanical Circulatory Support at New York-Presbyterian. Dr. Sayer provides leadership and oversight for the comprehensive heart failure services provided across New York-Presbyterian, including the campuses in Manhattan, Queens, Brooklyn, and Westchester. Dr. Sayer attended medical school at the University of Pennsylvania, followed by internal medicine residency at Columbia University Irving Medical Center. He completed his cardiology fellowship at Mount Sinai Medical Center and his advanced heart failure fellowship at Massachusetts General Hospital. Prior to joining New York-Presbyterian in 2019, Dr. Sayer worked at the University of Chicago for 6 years, where he was the Associate Director of the Heart Failure, Mechanical Circulatory Support, and Cardiac Transportation programs. In addition to his extensive clinical experience in all aspects of heart failure, Dr. Sayer has published 100+ peer-reviewed articles in the field of advanced heart failure. His research interests include the impact of heart failure treatments on cardiac physiology, with a particular interest in the interaction between patients and mechanical circulatory support devices. Welcome, Dr. Sayer.
Thank you so much. Thank you so much, Elizabeth.
Yes, absolutely. Next, please welcome Dr. Kamuda Ramasubu. Dr. Ramasubu is a heart failure cardiologist in Brooklyn, New York, affiliated with New York-Presbyterian Brooklyn Methodist Hospital and the director of heart failure there. She received her medical degree from Germany. She went on to complete a residency at the Cleveland Clinic and a fellowship at Baylor College of Medicine. Her clinical interests include advanced heart failure, cardiogenic shock, transplant cardiology, and ventricular assist devices. Welcome, Dr. Ramasubu.
Thank you, Elizabeth. Good afternoon, everyone.
And finally, please welcome Dr. Jayant Raikelkar. He is a cardiologist who specializes in treating with patients with heart failure. He has specialized training in taking care of patients who have advanced heart failure who require heart transplantation or LVAD. He is also specialized in treating patients who have heart failure due to cancer treatment. Welcome, Dr. Raikelkar.
Thank you so much. Excited to be here.
So happy to have you. So I'm now going to turn it over to Dr. Sayer as he discusses heart failure with his esteemed colleagues.
Great. Thank you, Elizabeth, and thanks everyone to joining us today. We're very excited to be here, and we're very excited to participate in this webinar. Heart failure can be a scary word. It can be when you hear the words heart failure, you can think of some horrible things. And so we're trying to hopefully demystify it a little bit today and give everyone a little bit better sense of what it is when we talk about heart failure and what we can do to both prevent and to treat it. So I think we'll just start off. I'll start off with Dr. Raikelkar just to give us a little bit of background on what is heart failure. What does it mean when you say someone has heart failure? Because it does cover a lot of different things.
Thanks, Dr. Sayer. So the main function of the heart is to pump enough blood and nutrients to the rest of the body. And when someone has heart failure, what's happening is the heart is not pumping enough blood and oxygen and vital nutrients to the rest of the body. And so that's what we call is heart failure. And the heart failure disease leads to some symptoms and signs that we think about. So if the heart's not pumping enough blood to the rest of the body, patients may feel tired, they may feel short of breath, they may not be able to remove fluid from their body and may develop swelling in their legs. So these are some of the cardinal signs that we think about. And heart failure has many different forms, but the main thing that I think we focus on is they're not getting enough blood to the rest of the body and not enough nutrients and oxygen. And these leads to these cardinal symptoms of shortness of breath, being tired, and collection of fluid.
Thank you so much. So Jay, as you're well aware, there are many different varieties of heart failure. Can you tell us about some of the causes of heart failure? What are the big picture causes of heart failure?
Absolutely. So we think about all the causes that can make the heart muscle weak. One of the leading causes in the United States would be decreased blood supply to the heart itself, like coronary artery disease. So someone who's had a heart attack. We know that other factors such as high blood pressure over a period of time can cause weakening of the heart muscle. Diabetes is also a risk factor as well. Now, sometimes we think of the heart pump not pumping strong enough. We all need to relax more in life. And sometimes the heart actually becomes more stiff and is unable to relax, and which leads to fluid collection. So some patients develop heart failure just due to having a stiff heart due to symptoms or having disease processes like high blood pressure. There are some other causes of development of heart failure. There can be some toxins that can cause that. I happen to see a lot of patients who have cancer and may have some difficulty in pumping function due to the cancer treatments itself. But the main causes that Dr. Sayer was getting to over here would be blockages in the arteries of the heart, high blood pressure, diabetes, but there are multiple other causes as well.
Thank you so much. So Dr. Ramasubu, what about more common toxins like alcohol and drugs? Are these things that can cause heart failure, and how do they interact with the heart?
Most definitely. So toxins like alcohol and recreational drugs can definitely weaken the heart muscle and lead to heart failure, reduced pump function of the heart. So the recommendation, the general recommendation is to abstain from overt consumption of alcohol, which is, 1 drink for women per day and up to 2 drinks for men per day. Drugs, recreational drugs have also been associated with the development of heart failure, such as heroin as well as cocaine.
Is it possible to be born with heart failure? Is this something that you could have been, are there genetic causes of heart failure? Is this something that, you could have had inside your heart since you were born and shows up later in life?
Most definitely. We're learning more and more about these genetic causes of heart failure, and we're learning that, a significant proportion of patients likely have genetic mutations leading to heart failure later in their lives. Moreover, there are certain patients who have certain genetic heart defects, be it valvular defects or holes in their hearts, which also can later lead to signs and symptoms of heart failure.
And so what type of patients do you see in your practice with heart failure? Is it old patients, young patients? Is it, patients who have a lot of high blood pressure? Is it patients with diabetes? What do you see?
Sure. So I work in Brooklyn, and I would say the majority of my patients are elderly patients above the age of 65. And this is something, we know worldwide that it does, the likelihood of developing heart failure does increase with age. So elderly patients, and the risk factors or causes of heart failure, similar to what Dr. Reikelker had described, typically, high blood pressure, many years of uncontrolled high blood pressure leading to heart failure, or coronary artery disease, which means blockages in your heart arteries leading to heart failure. With respect to gender, I would say it affects, men and women equally. So those are that's the patient population that I see.
And is it something that could be prevented? If we control the blood pressure earlier in life, if we control other risk factors such as coronary disease early in life, can that prevent the onset of heart failure?
Most definitely. So there's, ample evidence, research showing that if blood pressure is well controlled and other risk factors are well controlled, this can definitely prevent the onset of heart failure, later on in life. So high blood pressure, diabetes, prevention of coronary artery disease, leading a healthy lifestyle with heart healthy diet and regular activity, exercise can prevent the onset of heart failure later on in life.
Is there ever a point where it's, I'm sorry to stick with you, but is there ever a point where it's too late? If I'm 65 and I have high blood pressure, is it too late to control my blood pressure and prevent heart failure, or can I start at any age?
That's a great question. No way, it's never too late. So yes, even if you're 65 and you're now diagnosed with hypertension, it's extremely important to control the blood pressure, and that'll prevent you from developing heart failure down the line, typically 10 or 15 years down the line.
Jay, I'll swing it back to you. Is it possible to have heart failure and not know it? Can you be walking around with heart failure and not have the diagnosis and not even be aware and have no symptoms?
It is possible. And I think what Dr. Sayer is alluding to, there's really a spectrum. And what Dr. Ramasubu was saying, those risk factors would place someone at an elevated risk of having heart failure. And it is possible that usually, as the heart pumps strong, we talk about a pumping function, and usually the heart pumps about 55 to 60%. But early on, if those risk factors go uncontrolled, like high blood pressure, diabetes, there can be weakening of that heart function, and many patients may not be aware of that. So especially in high-risk populations, and maybe our younger patients, they may not have those traditional symptoms of shortness of breath or fatigue, or they may be thinking there's something else, that it may not be heart failure. So it is possible to have heart failure, especially early on, and not know that you have the disease.
Is that common that patients may not know about it?
I would say as we have more and more technology, we're discovering that more and more, compared to 30 or 40 years ago, where we were not as advanced as checking, the function of the heart muscle with ultrasounds. We're discovering more and more patients, especially in types of heart failure that run in families. Once we know that one family member has heart failure, like Dr. Ramasubu said, we could screen other family members, and we're picking up more and more family members before they're even aware of any symptoms. So I think in the future, we'll continue to expand the population that we diagnose before they even have symptoms of heart failure.
So how do we, so now you're a patient who has heart failure, but you don't know about it. How might it end up getting diagnosed? How would you find out that you had heart failure, and what would happen?
Absolutely. So to make the formal diagnosis, it's a couple of things that we look at. First, as just talking to the patient and seeing if they have those classical signs that we talked about. Some of those warning signs could be waking up short of breath at night, noticing that your weight's going up and that your legs are swelling up. If you are having difficulty, going up a flight of stairs, and a couple of months ago you didn't have that problem, these all could be symptoms. So whenever we see a patient, we sit and we talk to them. We want to know how they've changed, over the last 6 months or a year. After that, we actually examine the patient and we try to confirm whether we're seeing excess fluid, swelling in the legs. Do we see, if we listen to their lungs, sometimes we can hear fluid in patients who have heart failure, that they have excess fluid in their lungs. So after doing a history and a physical examination, we have more sophisticated testing. Some of those tests include blood tests, and some of those are imaging tests where we actually are able to look at the heart with an ultrasound. That's probably the most common test that we use to see if the heart pumping function is weak. And later on, there are more sophisticated tests which we actually can measure the pressures of the heart and things of that sort. But that's kind of a brief summary that we use all this data together to make sure we've made the right diagnosis of a congestive heart failure.
Can fatigue be a symptom? Chronic fatigue, or you're always tired and you're not able to really do things because you don't feel like you have the energy?
You're absolutely right. So when the heart gets weak and you're not pumping enough blood to the vital organs, you can feel tired. And some of our patients with congestive heart failure, they collect a lot of fluid. And that sometimes becomes a little bit more obvious for us. When you see someone swollen up in their ankles, you think about congestive heart failure a little bit earlier. But we do have patients who just feel tired because they're not getting enough blood supply to their vital organs. And that's something which would be important for everyone to recognize, that they need to be evaluated to understand that cause. And so as Dr. Sayer was alluding to that, if you're feeling more tired than usual, if you were able to go up a flight of stairs or 2 flights of stairs 3 months ago, and now you're struggling to get up the stairs, you need to be evaluated. it certainly could be congestive heart failure. There are other causes of fatigue, but certainly some patients with congestive heart failure will notice that.
Okay, so we'll switch back to Kamuda. So Kamuda, now a patient's been given the diagnosis of heart failure and they get sent to see you. What would they expect from that visit? What's the first visit going to be like? How often are you going to see them? And what sort of tests might they expect to get?
Sure. So yeah, the management of patients with, initially newly diagnosed heart failure is twofold, I would say. One is to identify the cause of heart failure, to see why the patient is having heart failure and treat that. And the second is to treat the heart failure itself, the signs and symptoms of heart failure. So typically, we start the diagnostic testing that Dr. Reikalker had described, and then also start medications for the treatment of heart failure. These medications include fluid pills if the patient is congested and retaining fluid, which will allow them to, urinate out the excess fluid, and that helps them feel better. And also other medications which have been shown to, improve symptoms as well as survival in patients with heart failure. So these medications will be gradually started in these patients. And typically, depending on how sick the patients are when they initially present, we may see them more frequently, even on a weekly basis, to, every month until we get them stabilized.
You mentioned medications. So what kind of medications do we use, and how many medications can a heart failure patient expect to have to take?
Sure. So, there's been a lot of research in the last 3 to 4 decades, and we now have a good armamentarium of medications which have been shown to really improve the outcomes of patients with heart failure. So it improves their symptoms and quality of life, but also improve their survival. And currently there are 4 groups of medications that are recommended for the treatment of heart failure, which have been associated with improved survival and also quality of life. These include medications such as ACE inhibitors, angiotensin receptor blockers, also Entresto. The second group of medications are beta blockers. The third group of medications are mineralocorticoid antagonists, which are a weak type of water pills. And lastly, SGLT2 inhibitors, which were initially developed for the treatment of diabetes, but have now also been approved for the treatment of heart failure in non-diabetic patients.
Yeah, I would just mention, to add to that, those medications apply to the group of heart failure patients where the heart muscle is weak and the heart does not pump as well as it should. But there's also a group, I think Jay mentioned earlier, of patients whose heart doesn't relax well. And there's, in that group of patients, we use different medications that are more focused on removing fluids, some of the same medications and some different ones. So it does depend a little bit on what type of heart failure you have. But certainly you can expect, if you get a diagnosis of heart failure, that you'll be on several medications and probably be on them for lifelong therapy to help keep that heart working well. I'll switch back to Jay here. Jay, you mentioned earlier about cancer, and I know you do see a lot of cancer patients as a risk factor. For, the medications, chemotherapy to treat cancer can be a risk factor for the development of heart failure. Should everyone who has cancer, do they need to worry about heart failure? Does everyone need to see a heart specialist? Can you give us a little bit more detail about that?
Yeah, no, absolutely. This is a great question. It's really been remarkable to see our colleagues in oncology, the cancer doctors, over the last 50 years have developed a lot of medications that is making cancer patients live longer, and many of them are cured of their cancer. Now, unfortunately, we've also discovered over that time period that some of the medications they use, sometimes it's chemotherapy, radiation, or some of their newer medications, can cause stress to the heart and sometimes damage the heart as well. And so there are some specific drugs that if these patients receive, that we do screen those patients. I'll just name one of them. One of them was named anthracycline or doxorubicin. It was a chemotherapy agent that was used. And we do know that patients who get that type of chemotherapy are at risk. It's a risk factor just like having high blood pressure or having coronary artery disease. And so in close collaboration with the cancer doctors, we screen patients who would be at higher risk. So it's not all patients, okay? So it's not any patient who has cancer that has that risk, but we're discovering more and more patients. And we definitely we monitor closely those patients who are getting a higher risk form of chemotherapy or newer medications that are known to stress the heart. And then certainly those patients who have symptoms that could be consistent with congestive heart failure, we need to see those patients early on. And so we're really learning a lot in this field about the newer medications that come out that are used for cancer treatment. And we want to make sure that we work really closely with our colleagues in oncology, the cancer doctors. In fact, it's a new field it's a long name, but it's like cardio-oncology, where it's the heart doctors and the cancer doctors. We work together very closely to make sure we can get the best outcome for the patient, both from the cancer standpoint and the heart standpoint.
Great, thank you. And then, Kamuna, I'm going to swing back to you. You mentioned that you work in Brooklyn. I think one of the unique things about New York-Presbyterian is that we have a huge number of doctors who have specialized in learning how to take care of heart failure patients and really focus all their efforts on taking care of heart failure patients. I think we have more than 30 heart failure specialists across the city, which not only includes our two biggest centers, Columbia and Cornell, but also many hospitals throughout the city, such as Brooklyn Methodist, where you work. Can you tell us a little bit about the heart failure program at Brooklyn Methodist and how it works with the community there?
Sure. Yeah. So as Dr. Sayer described, so we are, part of a network of hospitals under New York-Presbyterian, spread out all over New York City, and the hospitals within the network, we work closely together to develop, unified standards of care. So regardless of where the patient goes to, which hospital the patient goes to, they get the, sort of the same standard of care. Here at Brooklyn Methodist, we have a growing heart failure service. Currently, we have 2 specialists here, heart failure specialists. And in our group, we also have nurse practitioners and physician assistants to help care for these patients. Patients are very appreciative as they can get specialized care locally. And the majority of patients we're able to take care of locally. If they have more advanced heart failure and require specialized therapy, then we do refer them to our specialty hospitals, which include Cornell and Columbia, for more specialized care, such as heart transplantation or heart pump implantation.
And I'll also just add to that we have a growing program in Queens as well, where we already have 2 specialists, and hopefully by this time next year we'll have 3 to 4 specialists in each of those centers. And we have programs in Westchester as well. So I really think that we're able to reach out to our communities throughout the city. Kamuna, I'll stay with you. One of the other unique things I think about New York-Presbyterian is that we've developed this remote monitoring program, which we call the Centralized Heart Failure Program. Can you tell us about that? I know you've sent several patients to be managed by that, and tell us about your experience with it and what a patient who is in that program would expect.
Sure. So yeah, this program has been extremely valuable, for our patients. So in this program, the patients are monitored through, various devices at home. This can be devices, simple devices such as a weighing scale and blood pressure machine, or even through a pacemaker, defibrillator, or more specialized devices, such as something called a Cardiomyopathy. And if someone's interested, we can talk about that a little more in detail later. But we're able to monitor activity on those devices, from the office while the patient is at home, and keep a close eye on our sicker patients. And like this, if the patient has worsening heart failure, we're able to diagnose that early on and initiate treatment early on and prevent worsening. So it's been extremely valuable.
Yeah, no, I think one of the great things is, so this program is managed by several of our physicians and a team of physician assistants. And I have many patients who have been enrolled in this program, and they seem to really enjoy it because they get a phone call a couple times a week from these physician assistants to check in on them, to follow up on any data that they've provided, whether it's their weight or symptoms or other changes that may have happened in their blood work, for example, if they've had new blood work sent. And they call out to check in, and I think can help guide those patients how to take their medications. We often make adjustments to the medications without the patient having to come into the office. And I think it's a very valuable thing because a lot of patients like the attention, but also the fact that they maybe don't have to see their doctor every time they need to have a medication adjusted. And I think it's a really nice way to follow them.
Another benefit I've seen is also that the patients really learn about their bodies and how the bodies change if they drink too much water or eat too much salt. So it's been a great learning experience for the patients as well.
Absolutely right, and they get very close follow-up, and I think they like it. I just will remind everyone that you can put questions in the chat. I know that's out there. I see a couple questions in the chat. Maybe we'll take a second to answer those. So the first question is, do you have any hospitals in Queens? And thank you for that question. So the answer is yes. We have NewYork-Presbyterian Queens Hospital, which is in Flushing, or close to Flushing, right, kind of in the middle of Queens. This is a very large hospital with many beds and a large inpatient cardiology service. We have 2 heart failure physicians there, and as I mentioned, hopefully by this time next year, we'll have 3 heart failure physicians there. There's a huge need for heart failure care in Queens. There's a really large number of patients, as we're finding out. And so we've been very successful in implementing several of these programs. Again, just as Kamuta mentioned, these patients can get full specialized care at that hospital without having to come to Manhattan for care, unless they're very sick and need very advanced therapies, surgical therapies that can't be offered at that hospital. But that is the small minority of those patients. Most of them can be managed out there and never have to come into Manhattan. So I think it's another way that we are trying to manage our patients kind of in their local communities. So the other question came from earlier. This one's a little bit more complicated, so I'm going to put Jay on the spot to answer this one. The question is, can the expedited infusion of monoclonal antibodies, presumably for COVID, followed by a 5-day course of remdesivir in the hospital, have caused heart failure?
This is a great question. And as we know, we're learning every day in the setting of COVID what the effects of COVID and the treatments of COVID can have on the heart. I will say that the infusion of the antibodies itself and the remdesivir is not a commonly reported event. And in having experienced this team, for the last, let's say 2.5 to 3 years, have been dealing with treating COVID patients. In our experience, I can say that for the most part, when we've seen weakening of the heart muscle and congestive heart failure in the setting of COVID, the cause has been the COVID infection itself. Certainly, if you had congestive heart failure before, we had patients who weren't aware that they had congestive heart failure. And the first time we saw them in the medical system was during the COVID pandemic. And so majority of patients that we saw that had heart problems and that may have heart failure in the setting of COVID could be due to having heart failure before, or actually developing stress on the heart in the setting of the COVID infection. Sometimes those patients can develop inflammation of the heart muscle. And so the COVID can actually cause damage to the muscle fibers. And that is very common compared to other drugs causing it. So it's hard to know without reviewing a specific case, but this would be very uncommon for that to happen in our practice.
Yeah, I guess one other thing I would add is that, sometimes some of the signs of heart failure, for example, swelling in your legs, can happen for other causes. And if you've been in the hospital and you've been getting a lot of intravenous medications, sometimes those medications leak out into not the medications, but fluid leaks out into your legs. And so it may look like you have heart failure or have one sign of heart failure, but actually the heart's working okay. It's just a consequence of you having been sick and in the hospital. So we, again, yeah, for this case, we would have to know a lot more, but there is certainly something to think about, but we'd have to investigate further before we could say that. Jay, I will stay with you. So now I've been diagnosed with heart failure, and I got put on the 4 medications that Kamuta talked about. Am I going to feel better? And will I always feel better, or will I always have symptoms? Can I ever have no symptoms? Tell me about it.
Yeah, no, this is a great question, a very common question. And whenever we start medications on a patient, we kind of ask ourselves, can I make that patient feel better and can I make them live longer? And those 4 medications that Dr. Ramasubu was talking about, we really know we can do that with those medications. And that's why we try to get them on them. And the whole goal is, as Gabe was saying, we want to get our patients to feel better, right? A question that comes up is, now that I have congestive heart failure, can I be a normal person? And I want everyone to know that you're not alone. There's over 6 million Americans who have congestive heart failure. And the vast majority can do very well on the medications. And we really believe that, the focus on taking your medications, having that relationship with your providers to make sure that you're doing well with your medications can improve your quality of life tremendously. And so we all have patients who at some point were admitted to the hospital and were quite sick. They had fluid, they were feeling very tired. And if we are able to get them on the right medications and, they're having a low salt diet and they're exercising, we can make them feel much better. Now, I will say, can we cure congestive heart failure? That's always a tough question. And a patient who has congestive heart failure, we always think of as a patient with congestive heart failure, but we can make them feel much better and be in control to make sure they have the best quality of life possible. And many of our patients can do really well, go to work, do their daily activities, be independent, be driving and doing all these things on these medications. So I think, Gabe, overall, our patients can do very well with these medications, but they remain on them. Unfortunately, we know that patients who unfortunately are not able to take their medications or may stop those medications might actually get worse and get back in the same situation or even worse than when they started. And so I think it's really important to have your game plan. It's not easy at first. It's overwhelming to see like, hey, they want me to take these medications, be on a low salt diet and do all this stuff. But we have to take the time to explain why that is. And I can tell you the vast majority of patients can do very well and they'll remain on those treatments.
I think Kamuta mentioned earlier that, there are some lifestyle changes like reducing alcohol consumption, which need to go along with it to ensure that the heart stays healthy. Is that correct?
Are you asking me?
Yeah, I'm asking you. Yeah.
Okay, that's right. No, absolutely. There are things that we focus on which are just as important as the medications, right? Sometimes we feel that we need to do something, take a medication. Salt is like a magnet for fluid. And so, we generally recommend at least less than 2 grams a day. If you can do less, that's even better. And so if you're on a, heavy salt, it's not common, as Dr. Ramasubu was saying, that when they're monitoring, if someone goes out and, had a high salt diet and had, hamburger, fries, etc. The next day they can see those levels go up right away. And so it's important to be on that low salt diet. There's some medications you want to avoid when you have congestive heart failure. Those are the NSAID medications like ibuprofen and Motrin. We generally think that those are not good for congestive heart failure. And exercise. We think of exercise like a prescription, just like a medication, staying active. That in itself has been proven to do a very good job for our patients. And I think sometimes we don't spend enough time talking about those things, but those are the foundational piece of treatment of congestive heart failure.
May I ask a question?
Sure.
We talk so often about heart attacks. And what I want to understand is like the difference between heart failure and potential for heart attacks. And if someone goes into the doctor to be checked for a situation where their clogged arteries could lead to a heart attack, can heart failure be determined from that, or are there completely different tests for that?
Yeah, I'll take that one. I mean, it's a great question. So, I definitely want to differentiate heart attack from heart failure, right? These are 2 separate things. However, they can be very interrelated, right? And so what a heart attack is, it occurs when you have a blockage in one of the arteries around the heart such that you don't get enough blood flow down that artery. Sometimes it can be completely blocked, and so you have a whole area of the heart that's not getting blood flow, it's not getting the oxygen and the other nutrients it needs to survive. And so what a heart attack is that tissue, the muscle that's fed by that artery is dying, right? And that's why there's pain and other symptoms related to it. And so heart attacks can be treated by opening up that artery. And if they get caught early enough, you open up that artery, you restore blood flow, you can go back to having a completely normal heart if you catch it early enough. Those patients won't have heart failure. However, if there's lasting damage after the heart attack, if there's scar formation or if there's a whole piece of the heart that doesn't move well after because the muscle has died, that can lead to heart failure, right? And so a heart attack comes before heart failure, but it's certainly one of the largest risk factors. I think Jay mentioned it's close to half of the heart failure we see is related to either a prior heart attack or disease in a lot of the arteries around the heart, such that the heart muscle gets weaker. So they are very closely related. They're not the same thing, but if you've had a heart attack, especially if a heart attack that was not treated very early, you're at risk for developing heart failure, and you need to be monitored closely by a cardiologist to see if you do develop signs or symptoms of heart failure. That can be done through, as Jay mentioned, blood work, through ultrasound, through EKGs, all the different tests that we might do on hearts to see what's going on. So I see that we managed to wake up, it looks like, the crowd, because we have a lot of questions rolling in. So I'm going to ask the next one to Kamuda. So this says, no known heart issues in parents, but if I have one sibling who had a congenital heart defect and her children each had a heart condition, one a different defect and one a murmur, does that raise risk for myself and my children for heart issues?
So without knowing the specifics, I mean, it is very possible, since some of these congenital heart defects are genetically predisposed. So I would say, I mean, typically we recommend the next of kin. It seems like, you know, your sibling and then the sibling's children also have a heart condition. So I would recommend, you know, that your sibling's next of kin, meaning yourself, to be screened for a heart defect, yes, or mention it at least.
You start with just seeing a cardiologist probably, and then see what they would do next? Exactly.
General cardiologist, a good physical exam, EKG, and an ultrasound of the heart. That's what we would generally start off with.
Perfect. Jay, you were talking a lot about salt, but we have a question about water, and we often think of them going together. The question is, often we hear that people should drink 8 cups of water a day. Should heart failure patients drink less?
Well, we generally recommend some degree of decreased intake, right? And depending on those cups, of the regular cup size, you know, you should generally be getting close to 1.5 liters a day, okay? In some patients, if they're having a lot of fluid problems, it could be less, but we generally try to make that limit. So depending on your cup size, if the regular cup size, I think you're getting close to the limit with that. And we generally would be a little bit lower in those patients who are having fluid problems.
Yeah, I think it's very dependent on patient to patient, because some patients have a tendency to retain water and others do not. And so in the ones that retain water, we have to be very careful with how much water they're taking in. I will go to another question we have over here. It says, my 50-year-old brother recently had a stroke and was told it was caused by HCM, that's hypertrophic cardiomyopathy. He was also told it's a genetic variant. What checks can I do to find out if I have HCM and start taking precautions? Any questions I should ask my doctor? So Jay, I'll go with you.
Yeah, no, I think it's really great that the diagnosis has been made, and I hope that your sibling is doing well. And on that basis, we know that hypertrophic cardiomyopathy does run in families. And if there is an actual mutation that is positive, it's actually easier to know if you have the condition, because you could be screened using the same genetic testing, right? In many cases of hypertrophic cardiomyopathy, we're getting better at it. If we don't identify that mutation, then we would do the screening with an echocardiogram or that ultrasound of the heart itself. And so in this setting, if there's a known mutation, you could get similar genetic testing. And depending on the results, if it was positive, you would then have screening to see if your heart has similar changes of being, you know, extra thick. And that's what happens in hypertrophic cardiomyopathy, when the heart muscle gets thick and can't relax as much. And so it's generally genetic testing and screening by the ultrasound. And sometimes there are other tests as well. And the main thing is to make sure how you're feeling as well. Obviously, if you're having any symptoms like being short of breath or feeling more fatigue, or, you know, feeling like you may pass out, then you would want to see a doctor regardless of what that testing shows.
Great. Kamuda, next question for you. Can you address the role of psychological stress as a risk factor for heart failure, especially with the ongoing pandemic? I think we've all been under increased stress.
So psychology and heart failure, yeah, I think it's a very interesting topic. And I must say that many of our patients, because they suffer from chronic symptoms and limitations. It's not unusual for a heart failure patient to suffer from depression. So we do screen patients, for depression, and studies have shown that patients with heart failure who have depression, untreated depression, are at higher risk of worsening heart failure and also death. So if a patient has heart failure, it is important, to treat. If a patient with heart failure has depression, it is important to treat the depression. So, psychology and sort of disease go hand in hand. There is another entity called stress cardiomyopathy, which we're seeing also more of, which the mechanisms we're not sure of, but in levels of high stress, patients can develop an acute cardiomyopathy, which with treatment with heart failure in the most situations reverses.
Thank you so much. All right, we have a lot of questions, so I'm going to just go through them. When should a person, this is for Jay, when should a person initially see a cardiologist? Should one wait to be referred by their primary physician? And the second question here is, how might a senior citizen strengthen their heart?
Okay, both very good questions. Now, I'm assuming that question is someone with heart failure, when they should see a cardiologist?
Correct.
Okay, yeah, absolutely.
Or are there symptoms that should make them see a cardiologist, I guess symptoms concerning for heart failure? Mm-hmm. And do they need to wait to be referred?
Yeah, so we work very closely with the general medicine community as well, right? There are great doctors who are able to make this diagnosis and will put patients on great medications. I do think once there's a new diagnosis, it would be reasonable to see a heart failure specialist to make sure that we do all the testing that's required to understand the cause of the congestive heart failure and make sure that the regimen would be the best one for the patient. From the heart failure side, we always feel it's better to be earlier than late. And then many of these patients, if you're doing quite well, we may see once every 4 months, 6 months, or even there's some patients who are doing really well, we might just see yearly. But I think it is important to have that initial visit to make sure that we have done the full, thorough investigation, and also we can determine what the likely rate of progression is. So I think earlier is better, in my opinion. I think the second question was regards to, can you remind me, Gabe, what was the second?
What can a senior citizen do to strengthen their heart? I think you addressed some of this, but what are sort of some heart healthy things to do? Especially
Absolutely. And this is an excellent question, because the majority of patients who are diagnosed with congestive heart failure, as our population is aging, are senior citizens. And it's even more important for those senior citizens, right? Because over time, when you have weakening of the bones and you have weakenings of the muscle, it's even harder to stay active and exercise. And so for our population of senior citizen and what we call geriatric patients, it's even that much more important to be on a regular regimen of activity, right? And sometimes it can be harder, right? When you get older, you might develop arthritis. You might have other deficits, if you have some deficit with regards to visual deficits. And we work closely with those patients to understand how best they could exercise, right? So if our patients may have bad knee problems, right? Instead of going on a treadmill, maybe it's easier to be on a bicycle. Aquatics, things of that sort, putting less stress on those knee joints. These are all type of things that we could work together to make sure you can have that exercise regimen. Sometimes it's harder for some of our geriatric patients to make sure they're taking their medications regularly. And we always want to make sure there's a system in place where we can help them with that. And there's a lot of things, whether it's, by apps or by the use of reminders on their phone, larger pill boxes, all these things together, we need to tailor all these things to make sure that our senior citizens are getting the benefit of the most, with our best treatments up to date in 2022 for heart failure.
Thanks, Jay. I'm going to stay with you. We have some really great questions here. So this one's kind of up your alley. Can removal of a non-cancerous tumor in my heart cause heart failure? I had open surgery 15 years ago to remove a tumor and was just diagnosed with systolic heart failure.
Okay.
Are they related?
Now that's a great question, and I hope that you're doing well with the systolic heart failure. I can tell you throughout NewYork-Presbyterian, we have one of the largest experiences in cardiac tumors, and there are some patients who may develop systolic heart failure. Now, it's hard to say without the details here. It really depends if the location of that tumor affected the function of the heart later on, as in there were parts of the regular heart muscle that were removed together, or maybe some of what we call the conduction system, the electricity to the heart. I would say if it was a small tumor, and this was years ago, it may not be the tumor itself. but if it involved a part of the heart that's vital for contracting, there could be some contribution. Now, from the question, it seems that it was just the tumor that was removed. If there was any radiation or other chemotherapy along with that, then potentially that would be different. But it says it's a non-cancerous tumor. So I could say it's possible, but unless it was a larger one, it may not be the sole cause. But obviously, we would like to review that case in more detail.
The only other thing I would add is maybe, I guess, if there was some injury to a valve or something like that during the removal, that could also precipitate heart failure. We're getting towards the end, so I'm going to move on to the next question, see if we can get through all these questions. They're great. I'll answer this one. So my last 2 echocardiograms in 2016 and 2019 mentioned impaired relaxation, but ejection fraction was okay. Is this an automatic heart failure diagnosis? One cardiologist said to watch blood pressure, and the other told me to see a pulmonologist. I was a former athlete, but severe shortness of breath after more than 1 flight of stairs or walking uphill started in 2014. So this is a great question. So impaired relaxation, this is something that we measure with an ultrasound, with an echocardiogram, by looking at how blood flows into the heart. And Jay mentioned earlier that one of the types of heart failure that we see is hearts that don't relax well. And so certainly this can be a sign of that kind of heart failure. However, the caveat here is that as you get older, this is a very common finding on echocardiograms, even in the absence of heart failure. So this finding alone does not necessarily mean that you have heart failure. However, your symptoms are quite concerning. The fact that you've had such significant symptoms and we haven't figured out yet what's going on, I think does warrant a closer evaluation. Something that we occasionally do in these situations is a special type of exercise test on a treadmill with a monitor that measures how much oxygen you're taking in and how much carbon dioxide you're producing. And this can tell us a lot about the interaction between the heart and the lungs and whether there's any abnormality there that might cause us to do more testing. And so I would get this checked out. It sounds like you've already seen a cardiologist, pulmonologist, but if you're still stumped, I think going to see a heart failure specialist could be one way to try to see if there's anything going on with the heart that's beyond what's been seen already. So certainly it's possible that there's heart failure here, but this finding alone does not signify heart failure. Next question, I will give this to Kamuta. Should a 75-year-old man, and this might be a little bit controversial, with an ejection fraction of 45 take Entresto? Prescribe Entresto for the ejection fraction of 45.
Sure, that's a great question. It is controversial. However, Entresto has now been approved for patients both with heart failure reduced EF, i.e. weakened pump function, as well as in patients with heart failure, preserved EF, so with normal pump function. Having said that, I would need to know if you have symptoms as well. And but in the mid-range EF, which you're describing, you may be a good candidate for Entresto, but we would need a little more information.
Thank you. Yeah, I think this is a recent change for us. Previously, this category was not considered eligible for Entresto, but it's changed in the last year or so, so that we can prescribe for certain patients in this category. So, Jay, next question for you. I have a genetic predisposition to heart disease, but have no other known risk factors. Should I get a cardiac workup?
I think that's a great question. We might not need to know a little bit more about the genetic predisposition to heart disease, which family members were actually involved and what type of problems they had. Depending upon that, we could tailor it further. Within that, it's always important for those same risk factors to make sure the blood pressure, weight, diabetes, your cholesterol is under control. But I think we need a little bit more details with regard to, is the genetic predisposition due to blockages in the arteries? Is it coronary artery disease? If so, we would look closely. Sometimes patients need things like stress tests. Or is it due to heart failure itself? And in that case, some patients do need imaging of the heart if there's a strong family history. So if you have a little bit more details regarding what type of heart disease, you may need to see a specialist and to guide you through that, depending on what type it is.
Great. Elizabeth, do we have a few more minutes?
You could. I see there's a couple more. Why don't you take them?
I also have one question I wanted to ask Kamuta. So Kamuta, let's say we put our patient on the right medications, but despite this, they continue to have symptoms, they actually get worse, they get more symptomatic. How common is this, and what are the options for this type of patient? What should they expect?
Sure. So yeah, this affects, I would say, the minority of patients that we see. So a small percentage of patients, do not improve despite medical therapy and continue to worsen. We, of course, try everything we can to improve the patients with medications or, devices. We have devices to treat heart failure as well for select patients such as pacemakers and defibrillators. But if they continue to worsen, then we start evaluating them for advanced therapies, which include heart transplantation and implantation of a heart assist device.
Right. And I think you mentioned earlier that those types of therapies are done at the main hospitals, Manhattan, Cornell, and Columbia. And so we have very great, well-established programs at both hospitals that can take care of sicker heart failure patients. Again, a small minority of heart failure patients in general, but if that care is required, we have plenty of doctors at those two hospitals that can provide that care. We have a very long history. Our program is one of the oldest heart transplant programs in the country. Started doing heart transplants in 1977, and we're the largest in the country in that we've done more transplants over the last 35 years or so than any other program in the country. So we have a ton of experience. We've taken care of a lot of patients. We currently have about 800 patients who have heart transplants who we're following. If that care is needed, hopefully it's not, but if that kind of care is needed, we can certainly be there to provide that.
Thank you so much. I mean, I wanted to share with everyone the website. I did put it in the chat, but for you to get more information and be able to find a doctor near you, go to nyp.org/heart/failure, and you'll be able to get that information there. We're going to share that website as well with everyone via email tomorrow. This has been so incredibly informative. I'm so grateful, Dr. Sayer. What a fantastic job you did in getting speaking about all this information. Thank you so much for all of your time, Dr. Raikelkar, Dr. Rama Subu. So grateful that you all could be here with us today and be able to give us this really important information about heart failure. Please do follow up so that you can find the right doctor for you and be as comfortable and live as long as possible. So thank you for your time. Certainly appreciate it. I want to thank all of our attendees for joining us this afternoon. Thank you so much. Please, everyone, stay safe, stay healthy, and we'll look forward to seeing you on a future webinar. Have a great day, everyone.
Thank you, everyone.
Thank you, everyone. Bye.
Thank you.